Yes, my name is Marcelo Harada Ribeiro. I'm from Brazil, Florianópolis, and I have a case presentation of mechanic circulatory support in chronic total occlusion. After all these great cases of the colleagues, nice, frankly, amazing cases, uh, I, I have a case that's not so complex, but it's more to show the importance of this mechanic circulatory support as the most useful, that is impeller, in patients with high risk and depressed ventricular function. Then I will start showing here that the low ejection fraction is associated with poor outcomes. You can see here that in this study that patients lower the EF, more outcomes, more MACE we have. And since the first studies of Impella, US Pella, Protect 1, Protect 2, and Protect 3 that I will talk after, you can see that when the patient makes these kind of high-risk interventions in high-risk patients, uh, you can see that we can see an increase in left ventricular ejection fraction in all the studies. And in Protect 2, we can see a 29% reduction in MACE in patients that did protected PCI in complex anatomies, comparing Impella with intra-aortic balloon pump. Moreover, in Protect 3, you have to understand that Protect 2 was published in 2012. Protect 3 was a study that was published this year, in February, that the objective of this study was to compare the patients from the Protect 2 that you used 50-50 Impella 2.5 and intra-aortic balloon pump with patients using Impella CP. Most of the patients using Impella CP, it's a more powerful Impella than Impella 2.5, and some of the patients using Impella 2.5. Then and you can see that the results are very clear here, that the patients in Protect 3 using most Impella CP, they had better outcomes, they have less MACE in 90 days, showing a potential superiority of the Impella CP against Impella 2.5 and, of course, intra-aortic balloon pump. My case presentation is a male, 67 years old, hypertension, family history, dyslipidemia, diabetes, morbid obesity. This patient, there is a tricky history. He has chronic arterial disease with NSTEMI in May 2016. It was done. It was treated with a Promus in proximal LAD. After 3 months, in the same year, August 2016, this patient had another NSTEMI for intra-stent stenosis, treated with Zyme this time. And this case in 2018, 2 years after, this patient arrives to the hospital, to the ER, with another NSTEMI, and the EKG showing ischemia in all the inferior lateral wall with ST elevation in AVR. Using these medications, we proceeded to, it's not passing here, let me see, yes, we proceeded with the right heart catheterization, showing pressures increased in right and left chambers with a cardiac index of 1.29, very low cardiac index, and this guided us to enter with impella. We used the right femoral artery to put the impella and the swan guns, and the left femoral artery to pass a long sheet, 45 centimeters, and ABU 3.5, and we left a third access for the right radial artery with a JR 6 French. This was the case. There is a culprit lesion here. You can see that the circuit is the culprit lesion. We managed passing a filter for circuit for the marginal ramus without micro. It was very, very smooth. But you can see that there is also a CTO of RCA, but the plane was first treated the culprit lesion, that was the circuit and marginal, and in the same procedure treat the RCA CTO. We put let me come back. We implanted 3 stents in this bifurcation with a clot, 2.538 in circuit and a 2.2520 marginal ramus, make the kissing pot, and this is the final result of the circuit. Sin embargo, we make a tip injection in turnpike LP with good connections to PDA. Here is a hypercoat that passed through in this case, but it was very difficult to enter in the JR. We had to snare. At this time, we snare with an snare and R350. As Nasser said, I think that this is a very tip. When you want to externalize, I think that the R350 is much better than the RG3. We had success to snare, and then we finished with three stents, 3 sciences in this coronary, and the patient had a good evolution. And take home message is that there is little doubt that impella improves acute hemodynamic parameters during high risk PCI in high risk anatomies, mainly if depressed LV function. The PROTECT 3 study demonstrates superiority against of the impella CP against impella 2.5 intra-aortic balloon pump at 9 days with less MACE. There is the world of randomized trials data, but there is the real world of everyday clinical practice and the art of the medicine, like Nasser said in his lecture. And despite all these evidences, there is unmet decisions. Mainly, I think that which patients really need the impella, because I think that impella is a great tool, but we are doing a long time left mains, multivessel patients without impella, and we are having success. But of course, if you have impella in these patients with very depressed LV function, I think that's better to put impella. But we have to know really, and you have to have more studies, to know which are the really benefits of Impella, which patients have the real benefits to pass Impella. Uh, and then I finished my presentation, and I want to thank all the Colégio Colombiano de Hemodinâmica, with great operators, great friends, and thanks very, very much.